Good morning. Welcome to all the participants, both in person as well as who have joined us over Zoom. So today we have a particular appraisal using one of the risk of bias tools. We have previously introduced in our sessions on ROB2 tool for a randomized control trial, and we have previously done, Dr. Anuka had done one for crossover trial as well. So there is one more tool which is available as within the ROB2 checklist, which is for a cluster study, cluster design. So we thought we'll have a demonstration of that for assessing the risk of bias. So I'm happy to hand over to Dr. Reba, who has once again taken a lot of efforts to make this presentation. And she'll also be using a randomized control trial, which is interestingly used both crossover as well as cluster design in this. So we'll straight away move on to the presentation. Thank you, Dr.
Good morning. For today's session, we'll be looking at the critical appraisal of a cluster randomized crossover trial. Let's jump into the case scenario. So it is a monthly ward pharmacy meeting in the isolation ward. The committee is deciding the appropriate stock levels for various drugs and fluids. Your colleague who has recently returned from a stint abroad suggests that Ringer's lactate should be used instead of normal saline as the default intravenous fluids for resuscitating, as well as the maintenance fluid of choice. So his justification is that Ringer's lactate has chloride of 109 as opposed to normal saline, which has 154 milliequivalents per liter of chlorine. So he thinks that giving Ringer's lactate is more physiologically rational and prevents the development of hyperchloremic metabolic acidosis. So you review the evidence to see if that decision should be implemented and whether it will be beneficial for the patient. So after reviewing articles, you find this particular study, which has been published in NEJM in June 12, 2025. It's a crossover trial of hospital-wide lactated Ringer solution versus normal saline. Now let's go back to the basics. Suppose you and your friend go to a coffee shop and you want to order something to drink. If you drink strawberry milkshake and your friend drinks frappuccino, this is similar to a parallel design RCT, where one group of people get one intervention and the second group of patients get a second intervention. But what if you want to drink both the juices? So then you and your friend drink one particular juice. Maybe you drink strawberry milkshake and your friend drinks frappuccino. Then you drink a glass of water and then you switch the drink. This becomes a crossover design, where one group of patients they get exposed to both the interventions. So you have one particular period where you get exposed to one particular treatment group, then you have a washout period, and then you have period 2 where you get the second intervention. So what's the advantage of a crossover trial? So first, each participant acts as his or her own control. So it eliminates among participant variation. The second advantage is you need fewer participants to obtain the same power compared with the parallel group trial. And the other advantage is because every participant receives every intervention, each individual participant preference can also be measured in these kind of trials. So when to use these studies? One is if the treatment effect is very short-lived, then you can use it. And the underlying disease should be chronic and stable. Then you can use this design. The inappropriate settings would include, suppose the underlying medical condition itself progresses over the time period, then you cannot use this study. And your intervention, if it has a short half-life also, you cannot, if it has a long half-life, you cannot use it. And your first intervention, if it's going to affect long-term the result, the effect on a patient also, you cannot use it. And sometimes, if your washout period doesn't stop the withdrawal effect of the first intervention also, you can't use. For example, in a psychiatric trial, if you're giving haloperidol and placebo, if for the period A you give haloperidol and period B you give placebo, the minute you stop haloperidol, the patient will have rebound psychosis. So in those cases, you cannot use this kind of a trial. So the two main effects to actually watch out for is the carryover effect and the period effect. So carryover effect is the effect caused by the first treatment, which continues until the next period, and it alters the effect of the next intervention. So to prevent this, we need to use out a washout period. The period effect is the first and the second treatment are already separated by time. Sometimes the outcome you measure might not actually depend on the treatment, but might depend because you measured it in a different time. For example, scrub typhus, if it comes in summer season, if it comes in rainy season. Maybe rainy season scrubs are more severe, but because you measured that in different time intervals itself, that can change your outcomes. So, how to reduce this period effect and carryover trial and carryover effect? One is by using an appropriate design, and second is to use an appropriate analysis technique. So, one way we can do it is when you allocate patients, you must allocate equal number to sequence AB and equal number to sequence BA. For example, if you have 100 patients and you allocate them 50 to the top sequence AB and 50 to the bottom sequence BA, at the end of the period, you'll have the same number of participants in both the arms. So that will balance any period effect. But suppose you allocate the 70 people to AB sequence and you allocate 30 people to BA sequence, at the end of the trial, 70 people will be getting treatment B and 30 people will be getting treatment A. Suppose your disease itself has a poor outcome as the disease progresses, then you will have, wrongly you will say that treatment A is not working. So if you want to look at bias for crossover trials, if you type in Google, you will find this particular tool, which has been released on 18th March 2021, and you can use it to assess bias in crossover studies. Generally, all the risk of bias for developed by copying has basically 5 domains, which is applicable for almost all RCTs. The first domain happens when you have risk of bias due to randomization. So here, if you generate the random sequence allocation, if it's randomly allocated, and if you concede it, it will reduce this bias. The second bias can happen if the patients are not blinded, either the patients or the investigators. Here, what will happen is if they're not blinded, there can be some deviation from the intended intervention. The third problem happens when you're actually when you look at missing data. Suppose you have missing data and you omit it from your analysis, you can have one error where you call risk of bias due to missing outcome data. The next bias can happen when you're actually measuring outcomes. Suppose you're not blinded, you can falsely interpret outcomes. So a bias can occur there. Then the fifth domain is when you actually report your outcomes. So it is very important that you honestly report your outcomes. Whatever you have planned to analyze, you must report all those outcomes. If you have a problem in that, you will have bias in selection of the reported outcome. This is applicable to all studies. Special in crossover study is domain S, where you look for risk of bias arising from period as well as carryover effect. Now let's move on to the second type of study design, which is the cluster control trial. What we normally look at are just individual RCTs, where you have a huge target population, and then you have a patient, like an eligible population, like a sub population of the target population. You randomize these patients to intervention A and intervention B, and patients in intervention A can develop event or not develop event. Now, in cluster randomization, what happens is you group patients based on clusters. So, for example, it can be all the patients coming to one hospital, for example, CMC hospital, or all the patients going to the government medical college. So, these two are the two different clusters, or it can be schools. And instead of individually randomizing the patients, you're actually randomizing the whole cluster. For example, CMC gets one treatment, all the patients going to GVMC gets another treatment. So, this is called cluster randomization. So what is the advantage of doing this? It's logistically more feasible. For example, when we did the study, effect of salt substitution on cardiovascular events and death, in China they had taken 600 villages and they wanted to give substituted salt. That means it has less sodium chloride as compared to the normal salt. And they wanted to look at the outcome like hypertension or any cardiovascular effect. It's so difficult to give 1% normal salt, 1% substituted salt. It's more easy if you give one entire village substituted salt, one entire village normal salt. So when you want to do large trials, to make it logistically more feasible, you do a cluster trial. The second important reason why you do a cluster trial is to prevent contamination. For example, you do a vaccine trial. Suppose this clinician is practicing near North Vellore. This clinician is practicing in South Vellore. So both of them, all the and you do a study among both the hospitals. So if you give 1% vaccine, the 1% won't get vaccine, what will happen? In 1 year, if you follow up, even the non-vaccinated people will become immune to the disease because of herd effect. So what you can do is, Maybe the North Vellore clinician, you can give only vaccine. South Vellore clinician, you don't give any vaccine, you give only placebo. Then now what happens is you actually eliminate the herd effect and the patients don't get contamination. So that's when you actually do a cluster trial. So cluster randomization is useful when you need to implement studies from a logistical perspective as well as large-scale intervention. So population lifestyle interventions, community vaccinations, treatment guideline outcomes all use a cluster design. Now, some important issues in a cluster trial is consent. So if you look at a normal individualized RCT, first the patient must give a consent, then only you randomize the patient. But in clusters, what happens is the patients sometimes cannot give consent. The director of the CNC of an institution might say give consent for a particular treatment. The headmaster of a school can give consent for a treatment. And then the individuals might not be able to give consent. But what you can do is individuals can give consent to data collection as well as participation. I will come in more detail to this later in my presentation. The other important concept is clustering erodes statistical power. Okay, so compared to a normal RCT, your cluster is more statistically, it's actually less statistically better. Why? For example, we look at examples. Suppose these are all patients and they're all going to 4 different physicians. These patients probably prefer physician A. Why? Because there could be some geographic reasons. Probably he's living near their homes. There could be racial reasons, socio-economic reasons, ethnic, sexual, religious, political, or age-related similarities. So only similar people go to one particular physician. So each cluster will be different from each other because each of them will have their own cluster characteristic. So what will happen? The outcomes from this cluster will be very different from the outcomes in a different cluster. So this is called variation between clusters. So for example, in this cluster 1, this is cluster 2. If all of them say the same answer, the same outcome, if the cluster is so similar that everybody in the cluster will, if you do a trial, each of them will respond the same, then it's almost equivalent to having just one participant. Okay, so you do something called the intra-cluster correlation coefficient. It basically looks at the measure of relatedness of a cluster. It looks at the variance between clusters as well as the variance within the cluster. So this is the formula. SB2 means the variance between clusters, and here it's the variance between cluster plus the variance within cluster. So for example, how many patients are there totally here? 8 patients. Suppose all of them were similar and all the patients in this cluster were similar, technically you have only 2 patients in your sample size. So if the variance within cluster is 0, what will happen? The intra-cluster correlation coefficient will become 1. That means there is no variation within the cluster. Okay, that means your study will be very less, will have less power. But on the other hand, if everybody in your cluster is different, then your intra-cluster correlation will be 0. This will reduce the cluster effect. So when you're designing a statistical study for cluster, you must make sure that the ICC is close to 0. So the next thing is the effective sample size. So the sample size in clustered samples compared with the number of subjects actually enrolled in the study. So if you actually, this is a nice article which is actually published in the Annals of Family Medicine, where they explain this very nicely. So basically the rho is basically your ICC, that is your intra-cluster correlation coefficient. So for example, you have 4 physicians, each of them are looking at 32 patients. What is the overall sample size? 128. That is 4 into 32 patients. And this 32 it basically means the number of patients in each cluster. K is the number of clusters and rho is your ICC, that is your intra-cluster correlation coefficient. The effective sample size is given by the formula MK divided by the design effect. So this is the design effect. Suppose your ICC is 0.017. If you apply to this formula, your final estimated sample size is only 84. So this shows that overall the power you get from a cluster study is going to be much less than an individual control study. Suppose you keep that MK constant and you increase the number of clusters and decrease the number of patients, you can see that the power automatically increases. Suppose I want to get a power of 80 and I have only 4 clusters, that means I must increase the number of patients to at least 80 per cluster to get the same power of 80. So what are the challenges in a cluster trial? So first is there's a risk of imbalance between treatment groups. Like I told, in individual randomized studies, you have large numbers of you're recruiting so many patients. But in clusters, you can't recruit that many clusters. You can recruit maximum some 20, 30. So even small imbalances can have a major effect in your outcome. The second thing is selection bias. So because the individual patients are not giving a consent, suppose I go to one cluster, like I'm going to a hospital and the hospital randomized to one study design. If I later find out that, okay, this hospital is only going to give me normal saline, I might decide to withdraw from the study. So then you'll have something called selection bias in cluster studies. And the third thing is you can't really blind these studies. So cluster trial is more difficult to blind. So if you want to look at the bias for cluster randomized trial, you can again type in online. You'll get the ROB2 checklist tool to help you assess bias in cluster trials. So the only thing new in this consideration for cluster trial is they have a domain 1B, which looks at bias arising from identification or recruitment of participants into clusters. So now let's go and appraise this particular study. It's a crossover trial of hospital-wide lactated ringer solution versus normal saline. So if you look at the background, most of the crystalloid fluids which we use in hospitals are either normal saline or Ringer's lactate. But Ringer's lactate and other balanced crystalloid fluids like plasma like, the advantage is that they have reduced risk of hyperchloremic acidosis. When they have done systematic reviews, there has not been any mortality benefit. But people say that there is a chance that you have lower in-hospital mortality or there is a less chance of the patient that are requiring dialysis. So the aim of the study was to actually compare these two solutions as the main IV fluid to be given to the entire hospital. And they want to look at the incidence of death or readmission within 90 days of hospitalization. So this is the PICOT statement. So the population is hospitalized patients with an index admission. That means with no prior hospital admission within 90 days, the intervention is giving lactated Ringer solution. The comparator is giving normal saline solution as a default IV fluid. And your outcome is the composite of death or hospital readmission within 90 days. The time is 90 days. And the setting is actually in 7 hospitals in Canada. So the inclusion criteria at the level of hospital is the hospital should admit at least 1,500 patients per month. And they should have a level 2 or 3 ICU capacity. At the patient level, any patient who comes with an index admission with no prior hospitalization. Exclusion criteria is age younger than 1 month. If the patient has a missing birth date, an admission that did not meet the definition of an index admission, and if the patient was admitted during the washout period or the run-in period. So why is the RN contraindicated in less than 1 month of age? Because it's a calcium containing solution and it can precipitate with ceftriaxone and other antibiotics and can cause a precipitation in the baby's bloodstream. So less than 1 month, you won't really give Ringer's lactate. So the outcomes they looked at were, as I said, composite of death or readmission to the hospital within 90 days after the index admission. The secondary outcomes were death within 90 days after the index admission, hospital readmission within 90 days. What was the length of stay in the hospital? Did the patient require initiation of dialysis? Was there a visit to the emergency department within 90 days? Or at discharge, whether the patient discharged to a facility other than home? And the estimate was actually at the level of cluster, not the individual level. So the trial design was an open label, pragmatic, 2-period, 2-sequence, cluster randomized, cross-sectional, and crossover trial. Why cluster randomized? Because the intervention was actually implemented at the level of hospitals, not individuals. So they had chosen this design. So this is the flow. So once a hospital gets randomized to either fluid A first and then B, or they can go to fluid B and then fluid A. There was a 15-week period between the first intervention and the second intervention. So during the first week, the entire hospital gets stocked with the fluid. Then the trial gets run from week 2 to week 13, that is totally 12 weeks. At the end of at 14 and 15 weeks, they have a washout period. And then by the first week of the next 15-week period, again they will restock the hospital with a new fluid. Then week 2 to week 13 of the second period, they'll again do the trial. 14, 15, they'll have washout, and then the usual care starts at week 16. So this is how they did the trial. Okay, so the other thing to remember in this sort of a design, so this has 2 designs. It's a cluster, it's also a crossover. So an important thing to measure is actually the cluster autocorrelation coefficient. So how similar measurements are within the same cluster but at different time period? Is there how stable is the cluster over time? For example, if I get admitted in a hospital in March, the same nurses or the doctors might not treat me in September. So if the hospital remains stable between both the periods, it's good. But if your hospital characteristics changes during the time, then it is not good for the child. So you measure it by doing the between period intra-cluster correlation coefficient divided by the within period ICC. 1 means it has a high temporal stability. So when we design studies, we must always try to get this coefficient to be closer to 1. And if you look at the types of cluster crossover RCTs, you have a cohort, you have a cross-sectional design. So cross-section, what happens is the patients who come to period 1 are not the same patients who come to period 2. For example, in my study, all the patients who got hospitalized in period 1 are not the same as who got hospitalized in period 2. There's a difference. But for example, if you do a cohort type, what happens is the same patients who came in period 1 will be the same patients who will continue in period 2. For example, children who are going to school. If you, in the first period, you're trying one education technique, second period, you're trying a different education technique. This will be a cohort design. And in this study, the other thing they did is they did a sequential trial initiation. So instead of starting all the clusters at the same time, they have recruited each of the clusters in different time. So from 2016 to 2019, they have been recruiting patients. Then after 2020, they have stopped because of the COVID pandemic. So you can see that they have got only 7 clusters. And patients are not recruited on an individual basis. And all the clinical data were actually obtained from the database. So patients might not even have known that they were part of a trial. So during each period, what would happen is the hospital staff ensured that in the hospital, more than 80% of the fluid was the trial fluid. And when doctors order the fluid online, automatically that software will substitute the trial fluid. And even when nurses are giving it bedside, automatically they will be administering only the trial fluid. And every day they would have, they had a report which tracked the inventory of the lactated ringer solution and normal saline on all clinical strength throughout the hospital daily. So the funding of the study was by the Ottawa Methods Center. The funders was the Canadian Institute of Health Research and the Ottawa Hospital Academic Medical Organization. The fruits was actually got from Baxter Healthcare, but neither the funders nor Baxter had anything to do with the study. So we move on to the statistical analysis. So they wanted a sample size of 12 sites in this design to get an absolute difference of 1% in the primary outcome. They thought 16% would occur in the normal saline group and 15% in the reverse lateral group. So for this, they wanted 80% power, two-sided significance level of 0.05. The within period intra-cluster correlation coefficient was 0.006. As I told, it should be closer to 0. Then the cluster autocorrelation coefficient should be closer to 1. For them, it's 0.95. And they were assuming at 1,500 patients would get admitted per month to the hospital. And they've also looked for non-adherence. That from previous pilot studies, they have found that adherence with ringer's lac is only 80%, and adherence with normal saline is around 94%. They have also added 2 sites for approximate correction and 2 more sites to account for variation in the size of the hospitals. So totally they wanted how many sites? 16 sites. But how many did they get? Only 7. So the other thing is they have actually given outcomes only for the primary outcome. They have not really calculated statistical significance for the secondary outcomes. So when they did the analysis, they used the 2-step stage method of Hayes and Moulton. So at the individual level of the patient, they adjusted the patient for age, sex, Elliott comorbidity index, ICU admission within 1 day after hospital admission. Then they have summarized at the level of the individual hospital and trial period. And at the cluster level, they have looked at the linear regression for trial period, intervention as well as the hospital. And because they have done a sequential trial initiation, they have also adjusted for calendar time by using it as a continuous variable. And the other thing they have done is all the missing data for each outcome were summarized according to the treatment group. And if there was any missing baseline covariates, they actually use imputation. But this one doesn't really make a difference because they're actually concerned about the outcomes and not the baseline variables. But maybe for subgroup analysis, this is useful. So now let's apply this checklist and look at the biases. So the first question, was there any bias arising from the randomization process? Was the allocation sequence random? So yes. We had used computer-generated allocation sequence with permitted blocks of 2. Was the allocation sequence concealed until clusters were enrolled and assigned to interventions? They have mentioned that the randomization sequence was maintained on a password-protected computer and was concealed until 1 month prior to implementation. So probably yes. The third question is, did baseline differences between intervention groups suggest a problem with the randomization process? So probably not. Because actually all the baseline characteristics were almost similar in both the groups. So the mean age was around 58 years. It was slightly more female predominant. Most of the patients were from the urban area. And so this is the medicine patients, the surgical patients, the obstetrics patients, and the psychiatric patients. So this is basically surgery requiring emergency, urgent, or elective surgery, the ICU admissions, as well as the sepsis. The only thing different in the comorbidity was the patients getting normal saline had a slightly higher fluid and electrolyte imbalance as compared to the reverse lactate. Otherwise, all the other comorbidities are almost similar. So using this algorithm, I would give it a low risk of bias in the first domain. So now let's go to the second domain 1B. That is, some biases can happen when you do the following things. When you're randomizing the clusters, when you're identifying individual participants, when you're recruiting individual participants in the cluster randomized trial. So there are only 6 scenarios. First is, you randomize the cluster. Okay, and after randomizing the clusters, you identify participants, and then you recruit the individual participants. You might either recruit them individually or you might not even recruit them individually. Actually, our study did not recruit any participants individually. So there's actually some chance of a bias because you can have some selection bias. Good thing is to actually identify the individual participants first. Tell them that you're trying to do a study. That if they go to a particular hospital, they might either get treatment A or treatment B. If they're okay with it and they say yes, then you recruit them for the study. Then you randomize the clusters and then you go ahead with the study. That's the best. So here, because they have done, they have not recruited the individuals, I gave it a no. The second question is it likely that selection of individual participants was affected by the knowledge of the intervention assigned to the cluster? Probably not. For patients, it doesn't really make a difference whether they got normal saline or reverse lactate. They probably won't know the difference. The third thing was were there any baseline imbalances? There were no baseline imbalances. They have mentioned that they have actually waived out the patient consent because the intervention was actually a hospital-wide and it didn't really pose any individual risk to the patient. So overall, if you look at this, participants identified before randomization, no. Does it really affect the patient participants because of the knowledge of intervention? No. There were no baseline imbalances. So it goes back to the low risk. Now we come to domain S. This is because we have a crossover also in our trials. So was the number of participants allocated to each of the 2 sequences equal or nearly equal? Why is the question there? This is look at the period effect to make sure that both the sequences actually get 1:1 ratio. So here no. Why? Because there were only 7 clusters. 4 clusters got AB and 3 clusters got BA. So the 7 hospitals screened for participants, 700 randomizations. 4 got normal saline and then RL. 3 were given RL and then normal saline. So I gave it a no. But then in the analysis, we have looked for period effect. So I gave it a yes. Then was it sufficient time for the carryover effect to disappear? Yes. They have given almost 3 weeks for the carryover effect to go. So because of this, I gave the overall thing as low risk. Now we go on to domain 2. Was there any bias due to deviations from the intended intervention? So the first question, were participants aware that they were in a trial? Most probably not. Were participants aware of their assigned intervention during the trial? Probably. They will know whether they're getting RL or reverse lactate. Were carers and people delivering the interventions aware of participants' assigned intervention during the trial? Yes, it was an open label trial. Were there deviations from the intended intervention that arose because of the trial context? Yes. Because if you actually look at it, only 78.2% of the patients with RL got NS and 93.6% of the patients with NS got NS. So there is some difference in the intended intervention. And were these deviations likely to affect the outcome? Yes. Were these deviations from intended intervention balanced between groups? They were not balanced. In the RL, 78.2% was adherence rate, in the normal saline, 93.6% of the adherence rate. So it was not balanced. Have they used an appropriate analysis to estimate the impact of assignment to intervention? Yes. They had used an intention to treat analysis adjusted for cluster level analysis. So that was probably yes. So overall, in the first questions 2.1 and 2.5, I gave the high risk. Questions 2.6 to 2.7, it was a low risk because they had used an intention to treat analysis. But in the overall domain, if you have high risk in either part 1 or part 2, you have to leave it as a high risk. So I have given this as high risk. The third thing is, was there any bias due to missing outcome data? So there was no data which was missed with respect to the primary outcomes and any of the secondary outcomes. So data was available for all the clusters that included participants. So probably yes. So here also I gave them a low risk. The fourth question is bias in measurement of the outcome. So what's the method of measuring the outcome inappropriate? So they have actually all their outcomes they have actually got from databases. The mortality data was got from the registered persons database, and data on hospital readmission was obtained from the discharge abstract database. So there were so the method was actually appropriate. Were outcome assessors aware of the intervention received by study participants? Yes, they were aware. But will this really affect the reporting? No, because you're actually looking at hard data. You're looking at whether the patient died or not, whether the patient was admitted or not. So it won't really affect it. So again, if you look at the outcome, it goes back to the low risk the algorithm. Now the last domain, was there a bias in selection of the reported result? So here, all the data that they had wanted to analyze in the protocol, they have analyzed. And so multiple eligible outcomes are not, were not mentioned. And they not done multiple eligible analysis also. So overall here, it was a very low risk in the way they have reported their trial. So when I summarize it, of all the domains, almost everything has been low risk, except for domain 2, which has a high risk. Now finally, let's just move to the results. From the result part, we use the task questionnaire. So whether effects of intervention reported comprehensively. So they have given the differences and they have also given the confidence interval as well as the p-values. So if you look at the outcome, among patients who got VIGNESH lactate, 20.3% of the patients had a composite of death or readmission within 90 days after intense admission. On the other hand, normal saline had 1% more. They had 21.4%. But when you adjust them for all the cluster weight, the difference is minus 0.53, but it is not significant because the confidence interval is on either side of 1. And for this study, they have got the intra-cluster correlation coefficient of 0.064 and the auto-correlation coefficient was 1. And even if you look at the subgroup analysis, there was no great difference, nothing was majorly significant. They have also looked at, this is just to show that they have used period effect in their analysis and they found nothing significant. They have accounted for period effect. And the other sensitivity analysis they have done is they've removed elective surgeries, they've removed mental health case mix, they removed deliveries, and they have removed patients who could have experienced both routes, and still they found nothing majorly significant in any of their analysis. So, do the benefits of the experimental intervention outweigh the harms and faults? Suppose we assume that, so there's 1.1% difference, but there was not really statistical significance. But suppose it had come out as statistically significant. The lactated VIGNESH group would have an outcome of 20.3. Normal saline group would have an outcome of 21.4. The absolute risk reduction is around 1.1%. So the number needed to treat would be 1 divided by 1.1, which would be 91. So if you look at the cost difference between one RL pint and one NS pint, RL pint in CNC, the cheapest one is 57 rupees. Normal saline cheapest is 40 rupees. So the cost difference is actually 17 rupees for 1 pint. Suppose each patient in isolation ward needs around 5 pints during the hospital admission. The cost difference would be 85. So to reduce one outcome, the incremental cost would be rupees 7,735, which is not too bad. So will the results help locally? Would the experimental intervention provide greater value to the people in your care than any of the existing interventions? Not really, because of no statistical significance. So coming back to our case, at present, we would not have any policy change. We would continue using normal saline. But here you should note that the sample size is very, very low. So they had actually had the target sample size was 72,000, but they were able to get only 43,626. And if you actually apply the formula for effective sample size, the final effective sample size is only 1,090 for this particular design. So maybe if you had improved the sample size, increase the power of the study, maybe you might have had a benefit. And if it had any benefit, then maybe you can actually change the practice, because the incremental cost for one mortality effect is actually quite low, 7,000 rupees. Thank you.